Okay, everyone. Hello, how's the mic? Are we good, loud, and clear across the board? Thank you very much, video crew. Thank you very much to Westmoreland Manor for being able to host us today. My name is State Representative Eric Nelson. I am privileged to serve as a member of the House Appropriations Committee, and in that capacity, I'm the subcommittee chair on Human Services, which is really our key topic for discussion in today's roundtable. We do have some members that are en route and coming, so as people are going to be coming and going, and the first thing we'd like to do as we kick off this meeting is to stand and do a pledge of allegiance to the flag, which is over against the far wall. Thank you very much. As we begin this hearing and discussion across a very broad and in some, the eyes of the legislature, a bit of a nebulous program that as we've really seen grow in cost, we first want to be able to extend an opportunity to welcome from our commissioners. Commissioner Curtis, would you like to welcome us?
Yes, thank you, Representative Nelson. I want to thank, obviously, everyone for being here today to discuss about what's happening at the Westmoreland Manor from our reimbursements. The Westmoreland Manor has been in existence for over 100 years. With the county government as a whole, didn't matter from what party have invested and made sure that we have been taking care of our residents' need the most. And for you being here today, along with other state delegation, our state reps here today, discussing this matter is very important from our reimbursement aspect to make sure we continue with the Westmoreland Manor and providing the services as much as we possibly can across the board here. And I'm very grateful, Representative, to have this hearing today and have this conversation as a whole. So I appreciate everyone being here. Welcome, and to the best county in the Commonwealth. And thank you so much, and I appreciate it.
Thank you, Commissioner Curtis. With that, be able to have some initial remarks from the House Republican Appropriations Chairman, Representative Jim Struzzi from Indiana County.
Thank you, Representative Nelson, and I want to thank you for your leadership in putting this roundtable discussion together. And I will say I think the best county is slightly to the north of Westmoreland County. But I am originally from Westmoreland County. My parents still live in the Harrison City area, so I have a lot of respect for Westmoreland County as well, and I will actually be going to visit them after this hearing. So, but we realize going into this budget cycle that we face a very heavy lift when it comes to the cost of Medicaid. We already know that we're on the hook to cover almost $1 billion in funds that we are going to have challenges trying to find. So as we go through this morning's discussion, I think it's important that we understand why the costs continue to escalate year after year. And reimbursement rates are obviously a big part of that discussion on many levels. There are a lot of needs out there that we're trying to address moving forward. But if you look at this budget proposal that the governor has put forth, almost $52 billion, year after year, that continues to escalate. And we have to find a way to curtail some of the increases while also still meeting the fundamental needs that are out there for our community. So I do appreciate Chairman Nelson putting this together as subcommittee chair. It's very important that we hear from those people who are out there doing the work so we can understand what those needs are, how we can work to improve the delivery of services in perhaps a more efficient and effective manner. And I look forward to hearing the discussion today. So thank you.
Thank you, Chairman Struzzi, and we appreciate the opportunity to dig deeper in some of these subcommittee areas. We're going to next just very quickly go around the table to introduce members. There will be members that will be coming and going. I know we have some people that are en route that we'll be adding before we get into the testimony, but we'll go ahead and start with John, since this is your home turf here, just a general introduction, and then we'll work right around to Vicki.
Okay. All right. Thank you. I'm John Andersky. I'm the Chief Financial Officer of Westmoreland Manor.
I'm Vicki Laux. I'm the Vice President, Chief Operating Officer for Redstone.
Cody Jones, I'm the Senior Director of Government Affairs for the Pennsylvania Home Care Association.
Representative Eric DeVanzo, 58th Legislative District, the finest legislative district in the Commonwealth.
Great. I'm Matt Yarnell. I'm president of SKU Healthcare Pennsylvania, and I come from Center County, so just put that in the room.
Hi, my name's Carol Merrill. I'm an LPN here at Westmoreland Manor. I've worked here almost 28 years. Excited to be here, proud to be here.
Morning, everyone. I'm Zach Schamberg. I am the president and CEO of the Pennsylvania Healthcare Association. We represent nursing homes, personal care homes, and assisted living communities throughout the Commonwealth. I was born in Chester County, so I have to give a shout out to Southeast Pennsylvania. I feel like this is going to be a running joke throughout this hearing, but Mr. Chairman, thank you for the invitation today.
Absolutely. No need to introduce myself, just saying that we're in Steeler country, so this is black and gold territory.
Good morning, Matt Gobler. I'm the Chief Operating Officer for the House Republican Appropriations Committee.
Sean Curtis, County Commissioner.
Doug Chu, welcome to Westmoreland County. I'm one of the county commissioners.
Come home, go big, and have a ball from Greene and Washington County, 50th District, Representative Bud Cook.
I'm Janessa Nepschild, a direct care worker for Community Resources for Independence.
Rachel Moreland, I'm here for Senator Kim Ward.
Brian Rosal, 56th District, just down the road.
And online we have Representative Michael Stender. You know, Representative Cooper may also be. She had a double conflict. She may be jumping online with us as well. And my subcommittee. Oh, that's fantastic. It's a great entrance for Representative Marla Brown, who has not got her sea legs yet here at the manor. So once Representative Brown has a moment to sit down, then we'll have her hot mic right away, you know. So,
Hello.
Yeah.
Sorry, I'm a couple minutes late, but I'm glad to be here.
Yeah. It's great, and a big thanks goes to Representative Brown, Chairman Struzzi, and to the staff, the crew that came out here today to set up, the staff here at the Manor to make the room available. I know that this has been in works for a while, and our goal today is really to help drive discussion and listen so that we can better understand specifically the focus of the Community Health Choices program. My office, we prepared just a short handout that everybody should be able to have with the support from House Appropriations Committee. And we wanted to touch on this as we're beginning to set the stage from multiple perspectives here today to participate. And that's starting, this Community Health Choices program started statewide right about 5 years ago, 2020. And the line represents the number of participants. Those are Pennsylvania residents who are involved in the Community Health Choices program, and it's across the spectrum. So we have home care, we have facility care, we have private facility care, and we have the workers from all across the spectrum that's participating. And we see that through these 5 years, the costs of the program have grown from right around $3.5 initial billion a year to officially $6.8 billion under this line item, and an additional $300 million that comes from the lottery fund transfer. So, yes, she's going to go ahead and address the power washer at the time. You know, it is good timing to recognize we're here in a facility, and that facility needs to be maintained. You know, so. So as we talk about whether it's the lottery funds or the increased line item in the state budget, this budget, as Chairman Struzzi had mentioned, there's over $900 million new dollars coming to the program. And the conundrum that we struggle with is the accountability of those dollars. You know, during this same period of time in the last 3 years, we've had over 30 facilities, senior facilities close in Pennsylvania. We have a true recognized struggle in being able to recruit the much needed workforce for labor and pay. And we have a growing senior population. As we look at 2030, where we may have more 60-year-olds in the state of Pennsylvania than 30-year-olds, these numbers and these metrics are important components to say, moving forward, what improvements can we make to this program? How can we improve, you know, what personally I have a large concern with is this is a non-transparent line item. The House, the Senate is not able to see inside this $7 billion and better determine where those resources are going. So we've seen the program double in cost, but you'll notice the participants have only increased by less than 20,000 total citizens. So it begs the question, where is this investment going? Before we start testimony, I just want to hand it over to my subcommittee member, Representative Brown. She raced across the turnpike debris here. Representative Brown.
And again, I apologize for being late, but I apologize again for being tardy, but I'm very happy to be here with you, and I certainly appreciate my colleagues' effort to get this very important meeting together because as we move forward, we have this steep budget request from the governor's office, and it's our responsibility to our constituents and to the state to make sure that these dollars are being spent in the best way possible and that they're reaching the people that need them. So we look forward to your testimonies today and hoping to be able to come to some effective conclusions together as to how we make this more seamless to those who need it and also more transparent.
Thank you, Representative Brown. In the goal through the discussion today, I think it's important to thank the participants, you know, because at times in Harrisburg, it's challenging to work together on issues. And I recognize that we have diverse groups in this room coming from different perspectives in the state, and our goal today is to listen and learn from everyone because we're all in it together. We're all in it for our seniors. We're all in it for the infrastructure that's needed to ensure the continuum of care for our state's aging population. And as we move around the testimony, I know people are passionate on the issue. We do have an agenda in front of us, and to help for each member as we're in that 3 to 5 minute range, I have this little light with me today. So as the testimony starts, we will be in green. If we start to go over a little bit on time, we may shift to yellow. And if we're going a little bit longer than everyone, then we'll head to red. So if you see the red, then we want to try to hopefully stay in the world of green and amber. With that, we'd like to turn it over to our first testifier, and that is John Andruski, and he is the CFO, the Chief Financial Officer for Westmoreland Manor. John.
Okay, thank you, Representative Nelson. I want to also thank you for allowing the providers to come to the table to share what really our concerns are with our legislators. So I really appreciate that as well. I think one thing I want to start with is to make sure everyone's aware that the CHC program is very important for I know our Westmoreland Manor and on all long-term care facilities. It provides additional necessary funding for the Medicaid program on top of the traditional Medicaid payments. But what I do want to say is that for us, we've seen a decline in admissions over the last 5 to 6 years. So we've not seen a significant additional reimbursement through this program, especially when we take into consideration what is the intergovernmental transfer expense item. The IGT expense versus the IGT additional revenue within that CHC program. That expense item has gone up just as some of our revenue's gone up. So there is an issue of full transparency there because we don't know really, the IGT expense is going to the federal government to match those funds to come back to the state. We understand that, but it all seems to have been inflated, over the last 5 or 6 years or so. So one of our biggest concerns, one of our biggest challenges, and we have many challenges, the greatest challenge right now is staffing. And it's the staffing ratio mandates that are put in place that are causing our costs to increase significantly. In order to manage those mandates, we have to pay overtime, we have to provide maybe bonuses for our staff to pick up additional shifts. In addition to that, and most importantly, we're bringing in agency staff to cover that mandatory ratio. And we're still limited as far as our admissions because we just don't have the staff to completely staff all of our beds, nor do we have the admissions to do that either. So the challenges are significant, but the CHC program is very important to the Manor and I think long-term care across the state. But I think maybe what we need to do is look for maybe a more efficient way of operating that particular program.
I have to say, Mr. Andruski, you're setting the stage for, isn't that
Right.
you're
Well,
reaching
yeah, thank you.
the edge of your testimony of sharing. I know we're going to be having a round robin discussion. Before we advance, 5 years ago, what was the capacity and the numbers here at the Manor as compared to today?
And we still, today, we have 408 licensed beds, which we've had for many years. We were, I believe 6 years ago, we were at 96% occupancy, which in my mind is you're fully occupied at 96%, 94, 95, 96. That's just turnover, in bed turnover. Today, we're at 56%. So we've seen a significant decrease in those admissions. On the revenue side of that, over a 6-year period, we saw a 3% increase in revenue from the CHC side. So I know that the days are smaller, and we did see an increase, but that increase amounts to not more than 0.5% a year over the years. And we've seen a significant swing from a 15% reduction in 1 year, a 20% reduction, a 10% increase the following. Overall in 6 years, it was only 3%. So for the program to be escalating at a much greater rate than that is just, it's puzzling.
Can you just clarify, the admissions are down because of the staffing ratios, or they're down because you just don't have enough applicants, or both? Both.
Yeah. There's a lower number of referrals that are coming into the facility, and if we increase those referrals, we may not have the staff to be able to do that anyway, to be able to take them. But I do want to say when it comes to staffing, there's a lot of different arguments you could have. We have a low volume of skilled care, which means we don't have high acuity residents here or high acuity needs. So for the state to just say, this is what you have to have, well, if we have that with less than 4% skilled, and there's another facility that has more than 20% skilled, then we actually have a greater staffing than what another facility might have. So I think that we're ignoring the acuity levels of our residents as well when we apply a staffing ratio.
Thank you. Thank you, Mr. Andruski. And with that, we're going to shift to Carol Merrill, if I'm saying that correctly. And it's great to see you've been here a good number of years. So looking forward to hearing your perspective.
Thank you. Like I said, my name's Carol. I'm an LPN. I've been here for almost 28 years. and I want to thank you, Representative Nelson, for allowing me to speak. Westmoreland Manor means a lot to me. It's more than just a job. I was raised here. My mother retired from here. She was a nurse aide. When I was in my teens, on the weekends when my mother worked, I would come up with her and spend time with the residents, do hair and nails, and be there for them, be companionship for them, because that's really important to them. My father was a resident here, and my grandfather was a resident here and passed here. My son works here. He's been here about 8 years. So like I said, this place is not just a job. It's very important to me. The quality of care at Westmoreland Manor is not as good as it used to be. This is common in all nursing homes in Pennsylvania and across the country. The reason is because of low staffing. There's just not enough time to give the care that we used to be able to give to our residents. We used to be so proud to work here. Our neighbors and communities used to trust sending their loved ones to us. Okay, so why do we not have the workers we need? Because these are essential and demanding jobs which care for the elderly and the veterans who our country should care about the most. But we do not compensate and value these jobs the way we should. Caring for a resident in a nursing home is different than in a hospital. Hospital patients receive treatment and then leave. For most nursing home residents, this is their home. Everything a resident can't do for themselves, we do. Showers, bathroom, getting ready to eat, feeding, any activities of daily living that they are unable to do for themselves. We provide love and companionship. We know our residents and know when they act different or when something is wrong. We know when they need a doctor because we know them. We're their advocates, their voices, which is important when they can't speak, move, or remember all the time. We do whatever it takes to help our residents live a dignified life. It's not possible to do everything in an 8-hour period with the number of residents assigned to one worker. It is the residents who suffer. They get touch-ups instead of full care. Residents do not get time with workers to talk. Companionship is one of the most important parts of caring. Workers also get frustrated because they can't give the care that they know they should be giving and they want to give. They just can't do it. They have to move on, just move on. I get emotional talking about my residents at the manor, which I always do, because we would not have the county if it wasn't for these people. The people we care for, they raised this county. But they're put at the bottom of the list when they should be at the top. They should feel important. When we are short-staffed and when workers are not paid competitive wages, then the residents feel like garbage, like they're not worth it. It makes them feel like the community doesn't care about them. We need to make nursing home jobs some of the best jobs in the communities. The wages and benefits of caregivers should reflect how much we value the care our seniors receive. I get worked up, I'm sorry. Like I said, this place really is, this is very important to me. This is very, okay. As a caregiver for over 2 decades, I believe we need to increase state funding for nursing homes. COVID took a toll. Sorry. COVID took a toll negatively, and caregivers fled from the bedside and have not come back. This is an undervalued and undercompensated job, especially when you work alongside agency staff making twice what you make. We need competitive wages and good affordable health insurance to grow our workforce. I also believe we need stronger accountability as to where the funding is spent. It should go to care for residents, including recruiting and retaining the best caregivers. I'm lucky to work at a county home and have a union. There are not many of our kind anymore. We have good health insurance because our union has fought hard to raise standards. Agency staff tell me how good the manor is compared to non-county homes, which is funny because I know the manor could be a lot better than what it is. They've also told me that the other non-community homes, workers don't have health insurance or they can't afford it. I've spoke with workers who bring in their own food from their homes to feed their residents because there's not enough food. So if a facility doesn't have enough food, where's the taxpayer dollars going? Sorry. Yeah. Okay, so this is why I think the key word is accountability. We need to uphold the state regulations that 70% of nursing home funding is spent on care. We also have to do better in making sure employees can and will meet the state staffing ratios. These are all standards that ensure operators, and especially non-county ones, are held accountable to resident care. I also believe when workers have a union, we increase transparency and accountability for our residents and communities. This is even more important for non-county homes, where their employers are not county commissioners voted in by their constituents. Through our union, we have the right to question and demand answers. We are able to advocate for our residents' care and have an equal voice in deciding where state funding is spent when we negotiate our union contracts. Almost done.
Thanks, Carol.
Sorry.
We'll move on to our next testifier. Fortunately, we're going to have a good bit of time to be able to talk, and I appreciate your passion. I want to head over there and give you a hug for crying out loud, you know. So thank you for what you do and for being such a strong voice for all of the employees here at the manor.
Thank you.
Know? Yes, our next testifier is going to be Mr. Matt Yarnell. He's the president of SEIU, helping to bring a statewide perspective.
Great. Yeah, first I just want to begin by thanking you, Chairman Nelson, for inviting me and Carol as the chapter president here and union leader to speak today. I also wanted to say I think our Commonwealth's investment in our long-term care for seniors and people with disabilities is in the most vulnerable communities matters a lot to me personally. My parents divorced when I was really young. My grandmother is who raised me and thought I should go on to work to make sure that folks get good care. And so I started in a nursing home myself at the age of 18 as a caregiver. And today I'm proud to represent our state's largest healthcare union, representing nursing home workers, home care workers, acute care registered nurses, and also some state nurses across the Commonwealth. I think you already hear like different sides of the spectrum in this testimony today. I think we have a growing crisis for folks who are aging in our Commonwealth, and we are not prepared for, I think the kind of tsunami of aging folks that are going to be entering into the system. We have a shortage of trained and skilled workers to be able to do nursing home work, to be able to do home care work in the community. And so we are, I think, really focused as a union on trying to figure out how do we solve the workforce crisis and also work with key partners to try to figure out how to do that in partnership. A couple things. Just one is we do support in the state's budget. I know we're talking about a lot of money. We do support the governor's proposal to invest $21 million in participant-directed home care. And the reason that we support that investment is participant direction right now is about 8,000 folks who work directly for their consumers. And it is the model of care that gets the state resources, the money the state puts in, directly to the consumer who has the most autonomy to then use that money directly on hiring their caregiver. And so we think that's an important investment. And I would just say the other thing on home care is the current wages for home care workers in Pennsylvania. The average wage for someone who's doing home care across the state is $13.30 an hour. It's a really important piece of the long-term care continuum. It's a spot where people have the ability to age at home with dignity, or for folks who are living with disabilities have the ability to have an active life in the community, but they need a caregiver to be able to help them get up, do their activities of daily living, and be able to be a functioning whole person in society. So we have a lot of work to do in home care to close the gap, to make those really good jobs. And I think that you'll hear accountability a bunch. We also do think that we should be being clear that the money that's going out is getting spent at the bedside on care, both in the nursing home industry, where we've done work together in partnership with the nursing home industry on 70% funds, making sure it's spent on bedside care. But in home care, there's not that accountability at the moment. We think that that should be added in the home care space. On nursing homes, I think you've heard about staffing ratios. I'm really proud of the work we did to increase staffing in Pennsylvania. We went from 2.75 hours, 2.74 hours a day of per patient of care to 3.2 hours with a mandated staffing ratio for CNAs and for LPNs. And even with those ratios, folks are taking care of 12, 15, and even 20 residents per shift. That's a lot of people if folks need all of their activities of daily living supported. So it's still, we think we made progress, but at the same time think there's more work to do there. And understand that there's real challenges on census, real challenges on getting the workforce, and frankly, in particular for nursing homes, we've never really recovered from the pandemic. These are not, glorious jobs. People still do not earn the kind of wages they deserve. People still don't have the kind of benefits that they need to be able to really do the job to the full scope. And that's a challenge. I think it's a collective challenge we all have. And we want to try to figure out what are the solutions, how do we work together to do that. And we know, one of the things to look at, and I think it's a little different in the county homes, and we're glad that you all still have your county home and have been committed to keeping it. But across the nursing home spectrum, about 20% of caregivers, 20% of nursing home workers are carrying medical debt. Like oftentimes people have health insurance, but it's not good enough coverage to actually pay for the kind of care that workers need. A couple other things just to touch on. I think there are really kind of three initiatives. So I think it is making sure that we advance the budget proposal to lift wages for consumer-directed home care workers. We are in partnership working closely with Pennsylvania Healthcare Association on a number of initiatives that are both aimed at solving the workforce crisis, but also making sure that the resources that you all have passed in Harrisburg actually get to the providers. And so we are advocating together for setting a stable floor of funding. And so that is the BAF legislation, setting the budget adjustment factor at 0.90 so that there's not this constant swing and that providers can have predictable funding going forward. So that's a really important initiative to us as well. So I think I hit the three kind of key remarks for us, but we're really, again, happy to be in this conversation. I think it will be a little bit all over the place, but we know that's important, and we are committed to figuring out how do we get to solutions because people who need care really need care, and the workforce who are behind the scenes, often forgotten about, need to have dignified lives and earn the kind of wages that will attract people. So just again, really appreciate having the opportunity to speak to you. Thanks.
Thank you. Thank you very much, Mr. Yarnell. Our next testifier is going to be Mr. Zach Schamberg of PHCA, the Pennsylvania Healthcare Association.
Thank you, Mr. Chairman. So first, I just want to commend Carol, not just for her remarks that she delivered, but for the fact that I counted 16 different index cards. I have never seen anybody read off 16 index cards. I can barely keep 3 stapled pages together. So Carol, nicely done. And thank you for your remarks. I had prepared testimony today, and I actually want to push that aside because what John said is exactly what we hear across the state when we talk to our providers who we represent at PHCA. The multiple crises that this industry faces in Pennsylvania. Not only an access to care crisis where folks are forced to travel dozens, if not hundreds of miles just to find a nursing home bed, but the workforce crisis. The fact that we literally don't have enough people to fill our shifts, never mind the staffing ratios, that we don't have enough people to fill our shifts and to care for our aging population. And the chairman said it best, we are an aging state. We're the 5th oldest state in the entire country today. Our fastest growing population, or demographic rather, is 80 and older. And in 5 years, by 2030, the number of Pennsylvanians 60 and older will equal and then eclipse the number of Pennsylvanians 19 and younger. So I commend you for calling this hearing because we need to start thinking about this now not only thinking about it, but acting on it and making sure that we can care for our senior population, because we're struggling today. What's going to happen next year and in the next 5 years? Now, the purpose of this roundtable discussion and this hearing is to focus on community health choices. And I think about the intended goals of community health choices when it was implemented 5 years ago. And in my mind, there were two primary goals. We hear this all across the country when we talk about managed care. It's to give folks choice on what care delivery mechanism there is, and it will save the state money. And I think 5 years later, we can argue neither has happened. Based on the chart that you showed, we haven't saved the state money. And given the fact that there are 30 less nursing homes today than there were 5 years ago, there's not choice there anymore. We don't have that choice that we once did as recently as 2019. And I see some fundamental flaws in this program and in this system. And early last year in April of 2023, actually it's 2 years ago now, we submitted comments to the Department of Human Services because they issued an RFI, a request for information, when they were re-upping the Community Health Choices program, and they were going to look for other providers to do this. We submitted comments that to this day have largely gone unanswered. But I want to touch on some of those important comments and some of the important suggestions that we had to really fix this program. Number one, providers were promised 5 years ago, and even before that there would be an ability to negotiate rates, that good providers could negotiate better rates. That has not happened. We fought just in case for a rate floor, and that floor, unfortunately, is the ceiling. There's no negotiation. You can be a good provider, you can be a subpar provider, you're going to get the same rate. There's no negotiation, and that's not a good thing. That doesn't breed competition in Pennsylvania. We advocated for value-based payments, that again, good providers should be incentivized to provide good or better care. That has largely gone unanswered. We don't have those value-based payments that so many other states do. There are folks in nursing homes today who probably don't need to be there. They could be better served in assisted living. And we have argued and advocated for that population to receive care in assisted living using the state's Medicaid program. That hasn't happened yet, and we're now 5 years into this program. Medicaid pending, especially in Western Pennsylvania, there are providers who wait 6 months, 8 months, more than 1 year just to receive reimbursement for a Medicaid resident because the system stalls and it takes longer and longer and longer. I feel like the 3 managed care organizations, soon to be 5, should be partners in this. But that program hasn't improved. That mechanism within our system hasn't yet improved. There's inadequate reimbursement for brain injury residents. There are not behavioral health coverages. We pay about $700 less in this state than Ohio does for ventilator care and ventilator patients, which is why we're seeing less and less vents in our nursing homes, because providers can't keep up based on the reimbursement rate. Matt mentioned the budget adjustment factor, or the BAF, that quite literally withholds or pulls back funding that the legislature allocates. In fact, it never allocates it in the first place. We're going to continue to advocate for that, even in the midst of a tough financial and fiscal outlook for Pennsylvania. And finally, I think it's important to note, in years past, and John, I'm sure you would agree, if Medicaid reimbursement didn't keep pace with rising costs, we could make that up with private pay or with Medicare. But at the federal level, Medicare Advantage has eaten into that Medicare rate, where now Medicare Advantage plans are paying about 70% of a typical Medicare rate. And what does that mean? It means providers can't cost shift anymore. They can't make up for that reimbursement shortfall on the Medicaid side because there's less private pay, and Medicare Advantage has really gobbled up all the Medicare days. That's a lot of information. It's a lot of things and a lot of challenges that we're facing, certainly. But I hope that gets to the heart, Mr. Chairman, of why we're here today and what we can do to provide that accountability and that insight into this program that, as John noted, is so important for nursing homes across the Commonwealth. Thanks.
Thank you, Mr. Schanberg. I appreciate your testimony and perspective, state line. And we're going to have to just breathe in and breathe out a little bit. Like there's just some challenging discussion, but that's one of our goals, is to be able to hear some of what it is that providers and employees are facing. Our next testifier is from another important component, and that's the home health care and the direct care worker. You know, we have Miss Janessa Nepshield, yes. And just a little background which helped drive to this hearing today, because we're wrestling with these issues in Harrisburg, and I was meeting with a constituent, and Janessa was the direct care provider for that constituent, which is how we met just a mile and a half from here at the South Greensburg Diner as we're trying to better understand issues with constituents. So, Janessa, I know you're nervous, but I'm looking forward to your testimony today.
Thank you, Chairman Nelson, for inviting me here to speak. I'm Janessa, and I'm a direct care worker. I've been a direct care worker for about 4 or 5 years now, and I do enjoy what I do very much. I go to the consumers' houses, and I take care of their daily needs, cook for them, help them bathe, help them do everything in their homes. Some of them do choose this because they just don't want to do a nursing home, or they just want to stay close with their family. And I do enjoy doing this very much. And if it wasn't for financial help from my husband and everything, I wouldn't be able to do this, because the pay rate isn't there. But I really enjoy doing what I do. My company has had struggles with hiring people. They get interviews, but then nobody wants to come in for that pay rate to do what we do. And it's hard, because if I take a day off, I feel bad, because then there's no coverage for the person that I'm caring for. And they're in their home, not a nursing home, and they don't have the ability to have someone else come in and help them do what they need. And I do take care of one person who is bedbound, so she has more needs than most. And if nobody comes in for her, she can't feed herself, she can't do anything. So it's hard to want to take a personal day or want to take a vacation, because you know that nobody's going to be there for them. I don't know. I mean, I like what I do. I don't know if other people are able to do that. This job is good because of the flexibility. Single parents would be able to do this job, but the money isn't there for a single parent. Sorry, I lost my train of thought. Healthcare is a good job. I've always wanted to get into healthcare. My grandfather had visiting nurses, and I always, because of him and his health, I wanted to get into this journey. And you don't need certifications like a CNA or anything to do this job. However, you do need a little bit of training, and you have to have the passion and the want to take care of people and to do that for them. And some people have it, but the money's not there, so they can't do it. You're not able to do what you love and take care of people like that, because the money just isn't there.
Excellent. Thank you very much, Janessa. You did a fantastic job and really helped to paint the picture, as you said, without your husband's position and what he's doing. It would create a number of challenges. Our next testifier is Cody Jones, and he is with Pennsylvania Home Care Association. Cody, you're giving us the statewide perspective of people like Janessa throughout the Commonwealth.
Yeah, first of all, Janessa, you crushed it. So, big ups. And thank you for calling this hearing, Chairman Nelson, and Chairman Struzzi, thank you for being here. Thank you for being a host, Representative Brown, and to all the participants. We appreciate this conversation a lot. It's a very important conversation, and we look forward to the discussion. A lot of what I'm going to say has been touched on, but Pennsylvania is at a crossroads right now. We're seeing a growing gap between community needs and the care our system can provide. And to put a finer point on this, every month, over 112,000 shifts go unfilled across the Commonwealth, at least 112,000. 27% of pediatric nursing hours are left vacant. And these aren't statistics, they're real people that are going without the care that they need, like Janessa highlighted. The shortfall is not due to a lack of effort by the providers. Agencies are working tirelessly to attract and retain workers. They're raising wages despite stagnant reimbursement rates. They're improving benefits and adjusting schedules and expanding training and doing all of the things they can do, offering sign-on bonuses for direct care workers. And according to the OLTL rate study, our providers are passing through an average of 85% of every dollar that they get from the Commonwealth. So the pass-through rate is high because the market demands it, and it's also the right thing to do. In the current budget proposal, as Matt referenced, the rate increase that was proposed would only support 6% of the direct care workforce, so between 8,000 and 8,500 workers. And that's in the participant-directed model. This leaves 94% of the workforce and the agency model behind and excludes home-based nurses altogether. This risks creating a fractured system that sends a harmful message that some direct care workers are valued more than others. And we reject that strongly. We support the entire continuum of care. We believe there is a place for every model of care, whether it be a nursing home, whether it be participant-directed, whether it be an agency model. It all should be equally valued, and that's reflected in the budget. Or it's not reflected in this current budget, but should be reflected as far as priorities in the budget. So there's some important work ahead to ensure community health choices remains viable and responsive, and we're not passive participants in that conversation. As just like this conversation, we are very active and engaged in it, and we want to find solutions and are very open to discussion. But our ability to plan for the long term is constrained by short-term budget constraints. Our agencies are struggling to do everything they need to do and want to do on behalf of both the participants and our direct care workers. So I just want to say this isn't about politics. This isn't about whether they're unionized or not unionized, whether participant-directed or agency or nursing home or whatever. The entire continuum of care needs to be responsive to the needs of the Commonwealth, and we have a very serious concern that as we approach 2030, we are not going to have the bandwidth to support the level of need that we're going to be experiencing. So I made it through without seeing even the orange light, and I'm very excited about that.
That's outstanding. Thank you very much, Mr. Jones, for your testimony and broader state perspective as you're talking about the numbers of what may be coming. Was there anticipated the shortfall in those workers, like as Mr. Schamberg says, hey, we're going to have this many more seniors that are entering this category. Is there a target number of what is that needed number of workers?
I don't know the gross number offhand. I mean, it is 1 in 3 Pennsylvanians by 2030 are going to be over the age of 65. I believe that is 3.1 or 3.2 million seniors over the age of 65. So not all of them will be Medicaid eligible, but just as a population, as a total, that's what we're looking at.
Thank you. Thank you very much, Mr. Jones. Our next testifier is Ms. Vicki Laux, Vice President and CEO of Redstone Highlands, and glad to have you here. I know there was a different representative on the child care perspective earlier today at a different venue. So I know you have multiple facilities throughout the county. Looking forward to hearing your testimony.
Yes, well, thank you, Chairman Nelson, for the invitation. Redstone does provide services to over 1,000 individuals in Westmoreland County each year. We do have 3 retirement communities in the county and a home health, home care hospice division as well. I also have served as the Leading Age Pennsylvania board chair for the last 2 years, so I hear these same stories across the state. But I will share with you a couple of statistics from Redstone. We have a 77-bed nursing home. In that nursing home, about 30 individuals are recipients of CHC benefits. We provide about 13,000 days of care covered by Community Health Choices every year. The cost of that care, to provide that care, is $465 a day, and CHC pays us $306 a day. That's a loss of about $158 a day, or an annual loss of over $2 million. The cost of care continues to increase as our field navigates the nationwide workforce shortage that has caused wage rates to increase significantly. We're also now held to the state ratios for minimum staffing, and I know that Zach and Matt both spoke about those ratios, and we could debate the benefits of those, but my point is that one size does not fit all in nursing homes for ratios, especially on overnight shifts, which the staff there, the addition of the required staff on night shift has cost us about $200,000 a year, which is unnecessary when we're pulling those hours from other shifts. Matt mentioned that we moved from 2.7 required per day hours to 3.2. We have always staffed in the neighborhood of 4.0 or 4.1. So that piece was always there. Our commitment to quality has always been there. But making us staff overnight is not helpful. And then they both also mentioned the BAF. That's I don't know if everyone knows what that is, but the budget adjustment factor takes money and pulls it back from what is earned, if you will, from our cost reports. So for example, last year we did receive, or the budget did increase on the Medicaid line, if you will, but then the BAF was only 84%. So it pulled back 16% of the funding, which just kind of took that right out of the water. You know, we didn't really get an increase at all. So the budget adjustment factor is broken. We are asking for a 0.9%, for 90% of that to be the floor. I think we're all in agreement with that from an association perspective. And I think that's a good direction for us to head and talk about today. You know, the folks who receive the CHC benefits are Pennsylvania's most vulnerable individuals. Many of them don't have homes. Many of them live in nursing homes because they don't have homes. They don't have families. Many of them, as Zach mentioned, could be served in a much less costly environment like assisted living, but there are no payment sources for that. Medicaid benefits do not apply in Pennsylvania to assisted living. They do in almost every other state. So that would definitely cut back on the cost of Medicaid if we could do it in a lesser restrictive environment. Zach also mentioned mental health. That's a problem regardless of payer, so I won't go into that today. But you know, if Medicaid doesn't, if CHC don't increase the dollar rates per day for us, as the CEO at Redstone, myself, our board of directors, our senior leadership team are really asking, can we continue to provide that service to Pennsylvania's most vulnerable citizens? We've done it since 1980. We're committed to it. We're a mission-driven organization. We turn people away every single day because of staffing. Unlike John's note that admissions have decreased, we are seriously turning away probably 5 to 6 admissions every day, either for staffing or just because of capacity. Capacity is going to become an issue with 30 nursing homes closing in the state in the last 5 years. And you know, if you look ahead, you're going to see that in the next 5 years as well if something doesn't change.
Thank you, Ms. Laux. And our last testifier is Austin Cawley. He is the Legislative Affairs Director with Leading HPA. And Austin, you also made it in just under the wire today. Thank you for rushing
I
across the
apologize for
country.
my tardiness. Hopefully you won't hold it against me. Just thank you so much, Chairman Nelson, Chairman Struzzi, all the legislators for being here today. I'm Austin Cawley, Legislative Director for Leading HPA. Do want to touch, you had asked quickly about the number of workers needed. Leading HPA, PHCA, and the Hospital Association recently did a workforce survey. It's an estimate that we will need roughly 11,000 additional CNAs by 2030. Mind you, in the last 4 years, we've lost 15,000 CNAs off our CNA registry. So we are at a huge gap when it comes to the amount of workers available. And I think I'll tie that into the ratio workforce conversation here. I don't think any Leading HPA members, and we're 420 strong across the state, mission-driven, typically nonprofit. Again, you can hear it from Vicki, very passionate about caring for older adults. We don't disagree that more staffing or higher staffing levels are not needed to care for the seniors in this Commonwealth. Unfortunately, though, what is going on with the ratios is just operationally, they do not make sense for providers. For example, Vicki talked about admissions from hospitals. The example I like to give is because of ratios, because of a night shift ratio. Let's say you're fully staffed in a facility. I'm fully staffed, the hospital calls, hey, I have 2 admissions, can you take them? No. Unless I bring in somebody else, or unless I bring in the day shift LPN to work. Operationally, ratios just do not work for our providers and to continue to provide that high quality care. I'll also, again, echo everything Zach's talked about with the BAF. Obviously, we are very supportive of setting that floor at 0.9, making sure that it's sustainable and predictable. The BAF tends to adjust every quarter. So when you're budgeting going into the next year, you don't know what your rates are going to be in quarters 3, quarters 4. How do you, as an operator, how do you as a business operate in a responsible fiscal manner when you don't know what your rates are? But again, I know these are a lot of heavy topics here, but I'll just kind of run through, since this is about CHC and some of the managed care organizations, some of the issues that Leading HPA has identified, which Zach touched on a lot of them, so thanks for stealing my notes, man. One is the quality incentive programs, or QIPs. All MCOs offer quality incentive programs that add on dollars to a facility's base rates. Unfortunately, the QIP programs are all different amongst the MCOs. They all have different requirements. The requirements constantly change and rotate. A lot of providers don't know what the incentive program is in a lot of instances, and that's where we're finding that there are dollars potentially left on the table that the MCOs have that aren't making it to the providers. Behavioral health and what the role is of MCOs in that process. We know that there are a number of individuals that need behavioral health services that end up sitting in a hospital. They end up in different areas where their care is worsening, and then by the time they finally get into a managed care organization or get to a provider, their condition is beyond or is more expensive for the state to then manage that. Again, Zach mentioned about the negotiation of rates. Prior to CHC going into effect, there was a fee for service, so DHS paid directly to providers. After the transition to CHC, providers were told, well, you can negotiate higher rates with your managed care organizations. That has not happened. To Zach's point, we are essentially negotiating for the floor. And then finally, again, I'll touch on MA for AL, huge issue for Leading HPA. We believe that serving older adults in assisted living in that lower level of care can be cost effective for the state and allow seniors to be served in a more home-like environment and again, a better environment for them and making sure that they get the services that they need. And then lastly, MA pending delays. Again, Zach touched on it. There's a local provider here in the Pittsburgh area, $1.2 million in unbilled care through MA pending. They've since had to close 2 of their 3 nursing facilities. It is a huge issue that we are seeing, especially in Allegheny County, Erie, Philadelphia, a lot of the major population centers. And what that essentially is doing is allowing folks that are applying for MA while their application is pending. The provider in the nursing facility is still providing care, but they are not getting a dime for that care. So these applications go on for beyond the 45-day federally required timeline, and essentially these providers are supposed to eat and foot the bill for this care. So we definitely would like to see the MCO's role in how we can better manage that, because the sooner they can get into an MCO program, the sooner they can be overseeing that care and hopefully less expensive for the state. Thank you.
Outstanding. Thank you, each participant, for your perspective and information. We're going to shift now into the portion of the roundtable discussion and start with some members that may have questions, and then just kind of really organically let it flow. I'd like to be able to start with Chairman Struzzi.
Thank you. Thank you all for being here today. I think you've laid out the challenges before us quite well. Where to start? There's so much here, and I know that, you know, in the years that I've been in the General Assembly, I've been on Human Services, and we've been talking about this for a long time. And you have this program that's been around for about 5 years, and it doesn't seem like we're getting the results that we should be getting. So I have a couple of questions I think that would make good discussion topics, and that is, first of all, Department of Human Services is our biggest chunk of the state budget. And oftentimes when you have that big of an agency, a lot of stuff gets lost in red tape. So from that standpoint, and I hear this a lot, you know, you spend a lot of time basically covering the administrative side of things because there is so much red tape, and the costs that go along with that could be going to provide more services, or perhaps even, better salaries for your nurses and your staff. But again, it sounds to me like in a lot of these cases, the department isn't very responsive. And so now we're talking about, again, this Community Health Choices program that's been around for 5 years that doesn't sound like it's working. Do we change the system completely? Do we come up with a new system? Do we get rid of this system that isn't working? And maybe it could be working based on the stuff that Austin and Zach laid out if some of those things would just occur, but they aren't occurring. And again, the department, and I know all of us who have been in the legislature for some time know, they are not responsive. We have asked for some uniformity among the MCOs for some time now, and I don't believe we've seen those results either. And that accountability concerns me, and I think it should concern every taxpayer in this Commonwealth. So those kind of things I'm going to put out there, and the ratios seem like something that could be fixed. And I understand there's need for ratios in some cases, but it sounds like we need more flexibility as well, because if we can't provide the services at all, then we're completely failing. So I put those points out there for discussion. Anyone's, I welcome any more additional information. But again, I think this has been great. We really appreciate the information. We came to listen, and I think we've heard a lot. And hopefully we can walk away with some actionable items that we can try to pursue to address some of these challenges. So I'd open it to anyone for those comments. Thank you.
Mr. Chairman, I'll start, and thank you for your question. So first, you talked about the administrative burden. To put that into perspective, I think there is an administrative burden with this program that was supposed to alleviate a lot of those concerns. So if you're a 100-bed nursing facility in Pennsylvania, right now you may have residents who are part of 3 different managed care organizations, or they're contracted with 3 different MCOs. It's soon to be 5. So in each room that you go into, somebody may be working with a totally different managed care organization that's got different requirements, different eligibility criteria, and things that you need to work through. That in itself is an administrative burden. One of the benefits of this program a few years ago was positioned as that service coordination, which I think I may have mentioned, where we would have service coordinators to help us and to help our residents navigate the long-term care continuum. But more and more, our members are telling us the service coordinators are not serving their intended purpose, and we're delegating our staff that could be caring for our residents or making sure that the facility or the nursing home is running efficiently. We're having them be the service coordinators. Right now, the mandated ratio for a service coordinator in Pennsylvania is 1 service coordinator to 250 residents. 250. In our comments in the request for information 2 years ago, we said that should at least be brought down to 1 service coordinator to 125 residents. And I would argue if there are more coordinators out there, it should be even smaller than that. So more and more, we've seen that administrative burden really take shape on our nursing homes and in our facilities.
And as we're, shifting this a little bit into the roundtable portion, and members do have some questions, there are 2 other components, to the Community Health Choices program. One key component are the MCOs. Those are the managed care organizations that have responsibility, 3 providers. Zach had mentioned going to 5. They are in the midst of a lawsuit. We reached out to them to invite them to come today. They had agreed that they were going to participate. Legal came in afterwards and said, because of the lawsuit, we cannot have you participate. We also, which I can understand, there are more providers wanting to come. There are others wanting to keep, and so that they weren't able to be here. We also invited Human Services officially through the Appropriations Department. I was significantly disappointed that the official position of Human Services for Pennsylvania was that 2 weeks was not enough time for them to have someone prepared to be able to participate in this discussion, which I find troubling. Out of 14,000 employees in the Department of Human Services, and they really carry the managing role here, it's telling that they're not listening to you. They're not seeming to be responsive to the chair. It would be good for us to help understand, because this non-transparent aspect, we don't know what's happening once those $7 billion cross over the line, which are there opportunities for us to be able to better interact, or for you as providers, some oversight into the panel? The selection of Ozempic, the weight loss drug, was added by Human Services. It increased costs $1.3 billion to the state of Pennsylvania for non-medical necessity patients. That's $15,000 a year for every person. It was added, but I don't know if it was added through the coordination of you as providers or as the MCOs. Is there a tier of oversight that needs to be, placed, or some type of review capacity? Because we're now over 10% of the budget, and Human Services is saying they don't have someone who can speak to the details of this program. And I wanted to acknowledge Representative Tim O'Neill, House Whip, in leadership. Tim, it's great for you to join us today. Yeah.
Yeah, appreciate the opportunity to be here. Sorry, I was running behind. Getting caught up here on the conversation. So I'm sure I'll have a couple questions here in a little bit. But I'm from Washington County, and clearly this is a big issue that we need to get resolved. And just my initial reactions, Eric, to your point, the fact that Human Services can't have somebody ready to talk about this in a 2-week period is a little disheartening. Maybe we shouldn't appropriate 10% of our budget to them. Then let's figure that out. So.
Yeah. First, to the ladies who do it every day, thank you so much. This is a personal one for me, having had a difficult time finding home care for my dad, and then later having him in a home and taken care of till the end. But thank you both very much for everything that you do. You make lives better, and for the families too. For everybody down here, my question is, what has been the most inflated cost for you over the last 5 years? And then second question is, outside of ratios, what mandate would you like to see taken away from the state or by the state?
So the inflated cost is definitely the workforce. In a post-COVID world, we're paying so much more than we were prior to that, and it's well deserved. I mean, these ladies certainly earn every dime that they make. It just needs to be funded from somewhere. And what was the second part of your question? I'm sorry.
Outside of ratios, are there any mandates specifically that would make things easier for you outside of eliminating ratios?
There are a lot of antiquated regulations in the state from the Department of Health. When we have our surveys, a lot of things don't make a lot of sense. And I'll give you an example. So we went through COVID. Nobody died in our nursing home. We survived that, but we worked 24 hours a day, all of us. We didn't see a surveyor for 2 years. The first time they walked in the door, we had some dirt on a ceiling fan, and that's what they cited us for. And have at it if that's what you can find in our building, but where were you for 2 years to be supportive to us and to help us through this pandemic? So there are, I could tell you hundreds of regulations that are just no longer make any sense, but I won't do that today.
And are those regulations also cost prohibitive?
Yeah, I would say that they are cost prohibitive in some of the requirements from the regulations. The staffing ratios are certainly the biggest one there that's the cost prohibitive, but every regulation comes with a cost at some level. And we need regulations, I completely support that. But things that are not directly related to care aren't important, in my opinion. And Austin may be able to add more to that than I.
Yeah, I think to Vicky's point, I don't know if you can necessarily point to one specific regulation that's like overly burdensome. I think so. Mainly, our nursing facility regulations were updated 2-3 years ago. That included those ratios, but there was a whole litany of that means a complete overhaul of our regulations. I think what we've seen really is the enforcement of those regulations, and that's what's costing providers so much. We're seeing surveys across the state from field office to field office. I mean, average citations in one field office is 23 per facility, in others it's 2. We're seeing such a wide variance in how regulations are interpreted by the Department of Health. That is having an impact on providers because those are fines, those are star ratings. That all affects the bottom line. CNA training? Yeah, CNA training as well, which is a federal rule. So if a facility is cited, for whatever level of citation, if it gets to the federal level, because again they're all Medicaid, Medicare certified, CMS will implement a rule called the 2-year lockout. So they will shut down any CNA training program at that facility for 2 years, even if the citation had nothing to do with care.
Thank you.
I would agree with Vicki that one of our greatest increases in costs is staffing costs, but more specifically for us is agency staff. Of course, healthcare just continues to go up year after year. Pension costs are rather high, but for us to be bringing in staff, agency staff, temporary staff, when we'd rather have our own nurses in here, we feel that they'd get more consistent care with our own staff, and of course it would even be less costly than what we're paying today. But as far as other regulations, and I've not been in the healthcare or the home care environment for more than a year and a half or so, but in healthcare for over 30 years, and it seems to be a common thread in all healthcare industries is you have, for example, Medicare Advantage plans that aren't, and I think Zach may have brought that up earlier, that they're paying only fractions of what the Medicare payments would be. And so there's dollars there that aren't getting to the providers that are probably a cost within the Medicare program. So if something can be done within that realm of how those MCOs or Medicare Advantage plans specifically could reimburse facilities so we don't have to fight for every dollar. But yeah, there's some of the other regulations, whether it be the budget adjustment factor, staffing ratios. Staffing ratios, I think, just need to be a little bit more reasonable in that, just as I think Austin mentioned earlier, you can't bring an admission, or Vicki did, you can't bring admissions in because you don't have another staff person to bring in, but you have the staff, you're meeting your ratios, you're just not meeting them at that particular moment. So I think the ratios just need to be looked at and maybe made a little bit more reasonable, maybe a little bit more flexible.
If I could just add very quickly, as I said earlier, we are here to listen today, and one of the focuses of our caucus is regulatory reform, because we do think that there's too much government in a lot of cases requiring you to spend more time and cost doing things that in some cases aren't necessary. So whether it's through your associations or reaching out directly to your representatives, we would encourage you, when you see things like that in your daily activities that don't make sense, let us know, and we will do what we can to try and change that, because as we stretch dollars thinner and thinner, the way that we can put more money back into services and back into employee salaries is to get rid of some of that red tape that takes so much time. So I would encourage you, when you see things like that, let us know. So thank you.
Yeah, a couple things just listening. One thing I missed earlier, just to flag for all of us, is like this conversation's already challenging, but then there's also the conversation happening in Washington, D.C. that is going to have a very significant impacts on Medicaid and the program itself. And the one thing that I know that keeps coming up, we've been working really hard trying to make sure that we fend off the most draconian cuts that are going to directly hurt people, end users, but also providers. So there's going to be likely a new burden where you're going to have to renew every 6 months. That's going to be a challenge, I think, for providers who are already saying that they've got burdensome paperwork to be able to meet the program needs. So there's a lot happening in DC that could have a real impact on our state budget and on Medicaid recipients here in the Commonwealth that I think we should just flag. On DHS, I think it was a really important question, and I just constantly go back to the fact that the state is still the contract holder of these big MCOs, and so there's got to be some ability to direct what you want done. And so I think we're open to that conversation and figuring out how, if there are things stuck, we should unstick them. I know when we worked together around the staffing ratio originally and the $300 million state dollars, the $600 million that came along with that, we tried to think about what was the right way to be able to directly pass the payments through to providers so it actually got to the end user and didn't get stuck at the MCOs. So I think we're very interested in that dialogue and trying to continue to think about what is the ways in which the department actually has the contract, so they should be able to direct what needs to happen. So just to your point on a kind of panel of folks who can give suggestion. On the ratios, it's just complicated. I think a couple of things, there's multiple angles to be working on. Since COVID happened, there's not enough testing sites for CNAs, so we have the problem that people left the ranks, but then we also have the problem that right now that we have folks who are low-wage workers doing the work to get ready to test, and then having to drive 2.5-3 hours to a testing site only to have it canceled because Credentia pays too little, can't get an instructor. So there is real work to do on even being able to get people to get skilled up to be CNAs and tested. So we're, I think, working in partnership with the associations. I think Senator Ward has done a bunch of work on this, Judy Ward that is, on trying to how do we streamline and be able to get training more accessible and people tested. There's a lot of work to do in that space. Yep.
A joint hearing, I think it was Aging and Human Services, and this issue came up. Austin, you had mentioned that if a facility gets cited, they suspend their training, but workforce is the biggest challenge. So you have facilities that are not allowed to train, but again, it seems like Human Services, I don't want to say punted, but they assigned, we saw this with Maximus, where they took away the ability of the AAAs to be able to process people and went to a third party. Costs really increased, services went down. There's this now testing agency that doesn't seem to show up to tests. Is there an accountability voice that, whether it's from the employer side, the facility side, Human Services just walked out after they didn't actually testify? Where is that accountability component? Because there was a room full of people saying, do you need anything? And they basically said, no, everything was fine. You're saying it's a major problem.
We have I serve as the chair of the healthcare committee on the state workforce board, and we've actually done some recommendations to the governor's office directly and to the state legislature on testing and on trying to take the kind of disaggregated system and trying to bring it into hubs and trying to make sure that any sort of workforce dollars are going to kind of meet the moment. And Credentia continues to be a big challenge. And I think Zach said it in his testimony. There are 4 different groups. So I think you were even missing probably one at the table that day. So it's trying to kind of corral the right people to get to the accountability conversation feels really important. And the one thing we've been doing as a healthcare union, we work with and have a statewide training fund. And so we've been trying to actually get the ability to do online testing. And we'd still have to make sure people have some portion of clinical skill for CNAs. But even getting that approved is an act. It's just not it's not been possible. And so like that is one solution. We have an umbrella already that could do testing, but it's like we can't get the sign off or approval. So I think staying in touch with you, figuring out how to put a little plan together, and can we get the right people in the right room to push through the kind of red tape to actually solve the testing problem. Because I think we could lean in together and get a bunch more people tested and get people, you know, into this work. But it's going to take, I think, a group effort of industry, of government, of labor to try to solve it, because it's been unsolved, and it's really it's a real problem, and we're going to continue to see it get worse before it gets better.
Yeah, I know we had a question pending for Representative Cook.
Thank you, Mr. Chair. I wanted to let our chairman know and our colleagues how appreciative I am of having us, but more importantly, how appreciative I am of you providers coming in and share with us. I learned a long time ago it's more important for me to know what I don't know than what I think I know. And this just hasn't been an area that personally I've been involved in, so it's very educational for us to hear from each of you, and we want to thank you for that. I did want to put a question out there, being sort of new to it, if you will, as a compare and contrast of nursing homes as compared to assisted living. Zach might want to take the lead on that one.
Yeah, Representative, great question. So it's really in the level of care that someone would need, that a resident or a prospective patient would need. Nursing homes are your typical 24/7, very acute, high acuity resident, whereas assisted living, those are residents that need help with activities of daily living, whether it's dressing, bathing. You see a lot more memory care, dementia or Alzheimer's in assisted living, but you're starting to see more and more of that in nursing homes as well. So it's really what I'll call a lower level of care, assisted living, versus the 24/7 nursing home care like we have here at the Manor.
The last point that I'd want to make to you all and the general community, to Chairman Struzzi's point, don't assume that we as legislators understand everything. I always like when constituents show up and say, were you aware of this? Most of the time we're not. So please, please, please stay in touch and continue to reach out to us.
Yeah, can we dig just a little bit deeper in that MA for assisted living? We have heard this discussion in the past. The state has said that they're worried it would create a surge of participants and really skyrocket costs even more, but I'm hearing from you as providers that it would be a beneficial thing to do, and there would not be a overflow of people that would flood the system and couldn't get served.
Yes, so what, to Zach's point that it's a lesser level of service, the important thing to note there is that those people are now being served in the nursing home. They don't need that level of care. They just don't have any place else to go because they have no resources and there's not an opportunity for them in assisted living. So of the 30 people that we have receiving CHC services today, I would tell you that probably 20 of them could be served in assisted living. Our assisted living rates per day are much less than our skilled nursing rates per day.
So why the prohibition?
I don't know why the prohibition is out there. Maybe Austin can mention that, or Zach.
Yeah, I mean, I think when we look at assisted living, we're also just not talking about the senior population. We're also talking about intellectual disabilities, folks that are younger than the age of 60. That also can be served in assisted living. So I think DHS is concerned in those numbers. However, this has been a model that's been pretty successful in most states. I think we're one of 5 remaining states in the nation that doesn't cover assisted living services. So we know that it can be successful in other states, that we've seen it be successful. I think DHS's concerns about a woodwork effect, I think in a lot of ways DHS probably has a lot of power in how they control that. We also know that we're working on a couple different angles to see how we can try to limit what those financial impacts to the state could potentially be. But I think by and large, moving and transferring individuals that are currently served in a nursing facility that could be served in assisted living would no doubt save the state money.
And Mr. Chairman, just to that point, the woodwork effect has been disproven in study after study after study. As recently as last year, a study was conducted that looked at states that have moved to bring Medicaid into assisted living, and not only was there not a woodwork effect, but it saved the state money. Because our average Medicaid rate for a nursing home patient today is about $256 per day. To Vicky's point, the reimbursement rate for assisted living will not be $256 per resident per day. It may be $100 or $120 or even $150. There is an inherent savings there. And I don't want to gloss over the point that, again, it is the appropriate level of care. If somebody doesn't need to be in a nursing home, it's not good to force them into a nursing home. Let them stay where they can thrive. Now, I dealt with this, I'm going to get emotional now too, Carol. I dealt with this firsthand with my grandparents who had Alzheimer's and dementia and were lucky enough to be cared for in assisted living because we could utilize private pay. But if they were forced into a nursing home and that wasn't the right level of care for them, I don't know what we would have done. We would have probably sought care out of state. And I wonder if that's what families are being forced to do right now, especially with that growing Alzheimer's and dementia population. So I don't want to miss that point because cost is one thing, but the appropriate level of care is quite another.
And as far as the appropriate level of care, the home care industry totally agrees with that as part of the continuum. Those that can be served at home largely want to be served at home, and that cost is around half of the nursing home cost. So making sure we're paying attention to that population as well is super important. And we're constrained by our workforce completely. I mean, with those, I read out the missed shifts number early, and the cost to attract and retain an employee has significantly grown over this period of time as we've experienced contraction within the workforce. So just making you aware of that.
Yes, Representative Vanzo, I know you've been in the queue.
Maybe I should stay in the queue. Thank you, Mr. Chairman. My question is for Carol. I got a couple. Carol, in your statement, you stated stronger accountability. Can you give me a couple examples? Is there some policy things that maybe we could work on here?
So the reason I'm thinking so hard is because I don't want to say anything that would upset my bosses.
Okay, you're in a tree of,
Yeah.
you're in a cone of protection, Carol.
Yeah.
If you want to do an offline conversation, I'm okay with that. And the reason I'm asking is we can't fix it if we don't know what the problems are.
I would love to talk to you.
Okay.
One-on-one, absolutely.
Okay. And then the second part of it's more of a statement. Chairman Struzzi touched on it. Regulatory reforms are killing the Commonwealth here. Not just in this industry, our energy policy, our manufacturing. We are losing folks every day. We are losing our young population to neighboring states. We can't attract those folks here. But also tax dollars go with that. These are some of the workers that would be coming here to maybe be a healthcare worker. They are not coming here. It's just that simple. We are at a crossroads whole way across the state, and I think at some point we've got to roll up our sleeves and admit that state government, the bureaucrats, simply are not working for us. They don't have our best interests. We've got to get policymakers to the table that understand the issues to make the best decisions for our population, because as Chairman Struzzi said, moving forward, the dollars are only going to be stretched thinner. And there's going to be tough decisions to make. There's going to be cuts coming down the road here. Or are we going to raise taxes? But who are we going to raise taxes on? The same senior population. It's just not going to work. So at some point in time or down the road, we've got a real train wreck coming. And I think we've got some time to really address it here. And it's just whether or not we will or not. Thank you.
We're going to circle back. Janessa, I want to, draw you into this conversation where, from your perspective of the ability to be able to earn more Is there a pathway for you as a direct care worker to be able to, like, when you look at your 3-year future, can you see an opportunity for you to be able to earn those extra dollars that you need in order to stay in this profession? And if not, what might we need to do for, because there's a lot of you. Is it almost 100,000, direct care workers?
Well over 100,000.
Yeah. So how does your vision look, as you're sitting down with your husband and you're trying to plan, your kids are getting bigger, and you're like, what is my 26 and 27 look like?
I'd like to stay continuing being a direct care worker. I like being in this field. It would be nice if we could get more raises. I know it wouldn't be as much as like a CNA or a nurse and stuff like that, because I don't have those certifications in this, because we do home care, but I'm not sure. I mean, it would be nice if we could get somewhere and somehow. I know my company has said that whenever people quit, then hiring new people, it costs more to hire a new person, to train them and do all that stuff. We want to keep who we have, but it's just hard for them to do it because you can find job elsewhere making more money.
And so shifting, Janessa, over to John, going back 5 years ago, let's go back, 10 years. Carol, you may be able to touch on this. With this bottleneck that's been created by the state's training bureaucracy for CNA, 10 years ago, did they have that bureaucracy where people would be able to hire it and you could be professionally developed, so you could start and then you could, go through training and increase your skills, and there was a ladder that maybe you might have to go to the community college. Personally, I know people who they started here working, they were taking classes, they climbed up both the profession and the salary ladder. How did it used to be? Is it better now?
I can speak for Westmoreland Manor. We had our own training program here. We had instructors. They went through complete training here and got certified at our facility. And we had large classes. I don't know exactly why that fell by the wayside, but we used to train a lot of nursing assistants here and certify them here. And a lot of them stayed here because of that. I don't know if that helps.
I'm not familiar with that program. That program was here before my time, but I'll definitely start talking to some of the other leadership to see if that program's something we want to look at again, or whether, what might have been the limitations or restrictions on it, because that could be the possibility as well.
Yeah, I think there was a point, I don't remember the exact year. I know we worked in unison with a couple of providers back in the early 2000s to pass what was then the provider assessment, which was a way to we were going to run into a cliff where there was going to be not enough money to fund skilled nursing facilities. And we did that move, and then there was about a decade or more where there was really not increases to nursing homes, and you watched over that decade the actual the industry started selling off. It started to kind of reshaping itself, and I think that was a lot of the drivers. So you also saw regulatory citations go up, so people lost their ability to actually run their own classes. I myself went through a CNA course in State College at what was then University Park Nursing Center in the late 90s, 1998. There was a class of 12 of us. About 6 of us made it, about a year in, which was not uncommon. But yeah, so like we went from, most places being able to run their own programs, which was heavily dependent on the provider or the employer to get the instructor and to do the program and have the facility able to do it, to a model now where it's almost unheard of for folks to have their own program. There's a few out there, there's a few hubs out there that are, working with state workforce boards, et cetera. But we've kind of really moved away from that model. And part of it, I think, was the way in which we stopped, increasing, reimbursements to facilities. And it's crazy that I'm saying this, but I think Zach could show you, we lag behind, all of our neighboring states in terms of our Medicaid reimbursement rate. Believe it or not, as much as our challenges are with the money, we are less than our neighboring states. And the other thing I would just add on this conversation is we continue to be, folks have raised the cost of agency, and workers are voting with their feet in a tough economy. When you're competing with all of these other sectors that can raise their prices and pay more, you've got direct care work, which is really, really important work, and it is dependent on public funding. And so the question is, are we comfortable with putting the kind of resource in that we have to make these good jobs, and the accountability, to your question, to make sure that the money we're putting in gets to the worker and to the bedside or into the consumer's home, to make sure that we're able to make these careers. I serve on the workforce board, and the challenge with caregiving in particular for nursing homes or in-home care is the workforce boards are all geared towards how do you get workers to sustainable living wage jobs. And so there's very little money for this sector at all, federal dollars and oftentimes state dollars, because the work doesn't get people above the thresholds of poverty. And so that is just a challenge that we have collectively. And how do we pay for it? And what's the right approach? Last thing, and then I'll shut up on the ratio stuff. I think just to remind folks, and I hear you on the night shift challenge, but the ratios are 1 to 10 people on a day shift, 1 to 11 on an evenings, and 1 to 15 on nights. And when we were working to try to get somewhere on ratio, that's for CNAs. So that's a lot of humans to care for. And of course there's acuity out there. And then on nurses, I think it's 25, 35, 45 on the different shifts. So that's a lot of people to be responsible for. So I think there's still a lot of work to be done there. I also think that we need to make sure that we're paying providers appropriately. And I know that it's complicated for managers in particular who are managing the schedules to try to keep up with it. There are some things in there that we initially talked about on the ratios in the PPD, which was that the employer should meet it at 90%, at least 90% over a 2-week period. I'm not sure that's how it's getting enforced. So I would just say there's dialogue there. But I guess my final point is we have a challenge about the fact that wages for caregivers are low, oftentimes without the ability to have time off or health benefits themselves. We got to think about some big solutions that will cost money, and how do we make sure that the money is getting to the bedside. And last thing I'll say, when we were in dialogue with folks at the feds, I actually think there's a lot of money in the Medicaid Advantage programs that DC should be looking at versus Medicaid. Medicaid is a very efficient program, about 4% overhead. And when you look at when you look at other private insurances, there's about 18% overhead. So I just there's room here to be trying to figure out where are resources going, how do we actually solve the problems together collectively. Thanks.
So Matt, if I could just add to that ratio discussion just for one quick minute, because the night shift part that I wanted to make clear is, prior to the ratio regulation, we staffed our daylight shift at 1 to 8, 1 aide for 8 agency, or 1 aide for 8 residents. When the ratios came in order to cover that night shift ratio, we dropped that to 1 to 10. So it actually got worse on day shift and second shift when nobody's asleep, everybody's up, and that's when all the care is provided. So it just isn't necessarily logical. Again, I totally support staffing guidance and ratios and per day things. It's just, I think it just needs to be relooked at for how those occur. The other part I'll say is I have 2 very distinct sections of my nursing home. One is short-term rehab, where people come and stay 10 days. They're acutely ill. They need much more focused care than the folks who are living there for 5 years, who just need help, who could be in assisted living because they just need help bathing, dressing, toileting, and eating. They didn't have cardiac surgery 3 days ago. So there's a very different feel, and the ratios as they are now make it all standard, like every nursing home's the same, and it's vastly different.
Yeah, so Matt, your comments made me kind of think through some of this issue here. You mentioned reimbursement, Medicaid reimbursements specifically, and I apologize if this was covered before I was able to be here, but for surrounding states is higher. So, my initial question, and then forgive me, Matt, if you're not the person to answer this, but yeah, I figured, yeah. No pressure, Zach. So number one, why is that the case? What states around us, do they approach the reimbursement rates in the process of adjusting those rates differently than Pennsylvania? If so, how? Let's just start there.
Yeah, so great question. So we reimburse, as I said earlier, about $256 per Medicaid resident per day. Ohio is at $275 per day. West Virginia is at $355 per day. Maryland is upwards of $375 per day. New York, New Jersey, all are higher. And honestly, we have a lot of interaction with our counterparts in those states as well as folks across the country. And it really is the prioritization. We've got a higher senior population than all of our neighboring states, and that should be a priority. But as Matt noted, we went almost 10 years without any kind of reimbursement increase to nursing facility residents from 2014 to 2022. Now, there was American Rescue Plan funds and CARES Act funds at the height of the pandemic, but it wasn't a recurring Medicaid reimbursement increase, whereas other states did. They prioritized their seniors in long-term care, they stepped up, and they allocated increases. Not only that, we're one of 5 states in the country, as you've heard already, with a budget adjustment factor, or a BAF. So even when you do allocate dollars, as you did last year with a 7% reimbursement increase, as Vicki noted, not every single dollar is actually being allocated and directed to nursing facilities and their residents. And again, it inhibits our ability, or a provider's ability, to not only invest in the care that they provide every day, but to pay staff and to eliminate agency. Last year, we estimate providers in Pennsylvania spent nearly $760 million on agency staff. I don't want to say that's money down the drain, but that's money that and funding that could go to quality care and improving care and going to full-time employees. But instead, we're sending it to agency staff. So that gives you an idea of what we have here in Pennsylvania, the challenges that we have versus some of our neighboring states and where they've allocated resources.
You know, one of the things that I've always found interesting by the way the state goes about doing this is the fact that it takes an act of the General Assembly to adjust these rates, which, as certainly many of us around this table know, is it's always a massive effort to get done. So I guess if my question is more broad, really for anybody who wants to tackle, maybe nobody will. You know, if there was an opportunity to essentially throw out the system and redesign it the way it actually should work, is there any ideas on exactly how you'd go about doing that?
Well, that moved to a question I'm completely uncomfortable answering. So that is much larger than me. I just wanted to go back to the reimbursement rate issue because I am very comfortable talking about that. But all of our surrounding states, their PAS rate, they might not call it personal assistance services, but whatever, are at least 25% higher than us, including West Virginia, at about $4.25 more than us. Part of the reason that some of the states around us do a better job of funding that is because they do regular studies and evaluate where their rate stands in the marketplace. So we just did the OLTL rate study. The OLTL commissioned it through Mercer, and it said that we're about 23% behind as far as funding, but that was the first rate study we'd done in 12 years. So, and in that time, our rates had only gone up $1.91 over the course of 12 years. Meanwhile, agencies are paying their staff $4.58 more. So there's this growing gap there as far as knowing where we stand, evaluating our place in the marketplace, and then funding it that way. So.
Thank you, guys. I want to build on that question a little bit, or try to better understand, because as we're seeing through the information you're sharing, your rates are not going up, your wages are not, they're increasing for workers, but not at that same pace, where Harrisburg has doubled the investment in this program. I mean, it's increased, you know, from $3.5 billion. If we include the lottery funds over there, we're over $7 billion. So that's $3.5 billion more dollars are being spent on fewer facilities. And where do you see those dollars going? Because it's an enormous, there's a big elephant in the room. You know, we're running out of money. I mean, $3 billion more dollars, and there's only 15,000 more people being treated. it just doesn't, if it's not making it to the work, are there guardrails that we can put on this next billion that are going into this budget? Because there's a billion more about in a month or maybe a couple of months, depending on how things go. But is there a better way that we can invest this next billion so that we have that accountability and impact, you know, the employees and the training?
We think it would be really efficient if you gave $873 million to personal assistant services. That would be a very good investment.
Is there, I mean, John, you're not seeing those dollars, and I know we spoke in advance. We're seeing double the investment. It just is not making sense where these billions of dollars are going.
Yeah, looking at your graph, the cost of care has increased over those years, probably significantly, but not at the level that you see increases in the CHC program. So yeah, those dollars are going somewhere, but you know, like you said, we spoke earlier, is there transparencies within the MCOs to determine what, you know, what are they taking off of the program? What are they earning by operating this program?
And I am not saying anything bad about the MCOs, just in case they're listening. But the way they negotiate their rates is not transparent. It is a proprietary discussion between the MCOs and the Department of Human Services. So we're kind of not completely aware of the costs that go in. I mean, I know there are things, just to cherry pick one random thing, but the reimbursements to ambulance services, for example, has gone up significantly, and that was factored in to the increase in payments to the MCOs. So that's just one small example of the kind of costs that go into these negotiated higher rates for MCOs.
To the broad question, I just think figuring out how to get the kind of right table of stakeholders. I'll go back to what I said earlier. I think it's figuring out how to get providers from the different sectors across the continuum together, you know, government stakeholders, legislators together. You know, you want to obviously keep it to a size that you can figure out how to like get under the hood of the onion, because it feels like it's very much peeling an onion in long-term living in particular. And then I think some folks from labor. I think it's like we have an opportunity, I think, to you know, kind of put on the wall what, you know, where things are at, what's working, what's not, and try to think about, is there paths to solve it? There's also some other states we could look to who have, I think, much better deliverables in their home care systems, in their long-term care systems, and some of it is like the fact that they just have their rates have kept pace with the care they're trying to provide. But that's just an offering, is like figuring out what is the right stakeholder table to, and trying to do a conversation in a way that is like, not everyone just fighting for their corner, but like really putting on the table what are the ways that all the resources compete with one another, and how do we actually deliver care in the way we want. And then last thing is guardrails on the $1 billion. Like one thing you can do is attach pass-throughs, which I believe is still legal. So you could direct that you want the money that you're putting in to lift the wages and benefits of workers directly. And I'll just say before any providers freak out, and take into account payroll taxes and all of the things that come off the top. So, but that is one way to, you know, like get at it, is like, do we want to actually try to lift the wages and benefits of this workforce? If so, you know, I think you all do have, as the General Assembly, the authority and power to direct it, and take into consideration all of the things that come off that dollar for providers. Like, I don't want to pretend like that's not real.
And just to highlight this point, and this kind of goes to your actual question, which I should have answered at the beginning. When I said we're actively engaged in this discussion in my testimony, I meant it. We've been actively pursuing the creation of kind of a council that would evaluate that exact question from a systemic perspective. What can we do better? We are concerned about the longevity of this program in total. So we want to make sure we're doing whatever we can to be as efficient, effective, and transparent with the funds and how they're spent, making sure there's no waste, fraud, or abuse. So we make all of those things. We want to make sure we're protecting the longevity of the program as a primary resource for many Pennsylvanians. So we're actively engaged in answering that question for you.
Cody, if I could just have you clarify, you say you're actively engaged. As I'm listening to all this conversation, I sit on the Aging Committee as well, and the Health Committee, and I've heard a lot about the governor's Aging Our Way program. you know, as we anticipate this aging population and the needs of our state, did you all have a seat at the table? I'm just curious.
That was before my time. My CEO is probably texting me right now to answer that question on my behalf. I'm not sure. If I remember correctly, I do not believe we were, but.
Did any of you have a seat at the table?
Yeah, the administration held what I'll call town halls, public town halls. So there was the ability for our associations and for any group in Pennsylvania to provide input into that plan.
And have you seen anything tangible come out of that?
Well, I think I think the administration is certainly working through that plan, and there are parts of that plan that need to be implemented in the next 10 years. I mean, I talked again earlier about the dementia and the Alzheimer's population. That's a big part of that plan. There's certainly things that we would have liked to have seen that didn't make the overall plan, but a lot of the key ingredients of that plan are there, and hopefully they'll be carried through over the next few years.
Just to piggyback off what Zach said, yeah, our providers did participate in those listening sessions. I actually attended a few of them. They were pretty poorly attended. So, you know, I think from the department standpoint, I think it's well-intentioned. We actually fought to get life providers, so living independence for the elderly, which is it's like a home and community-based service, but it's actually an alternative to our MCOs that allow seniors to stay at home but also receive services at a life center where there's an interdisciplinary team of health professionals, kind of like a one-stop shop at the center, and then they also get the recreation. They can get help with activities of daily living, as well as meals. So really an innovative program that the department completely overlooked, and in final comments before the plan was published, at our urging, they added life into that as a part of the plan.
So I know we're going to be drawing to a close, and I appreciate the input, you know, from this. I mean, really, it's a cross section of the full senior continuum. This, you know, what we see, and Representative Danzo had mentioned earlier about the workforce or opportunities for that workforce. At the same time, you know, as we go back 10 years, and Pennsylvania had a $30 billion budget, and now we have a proposed $51 billion budget. The facility was fuller. The pay ratios were better. There were millions less being spent in workforce development. And, you know, I wonder if it's, you know, whether it's the need to step back from CHC or shine a light within, you know, some oversight boards of what's happening there, or even just interconnect the labor workforce development training to allow facilities to return to in-house training programs where, because there's a large bucket of money. I mean, it's millions of dollars for workforce development. And we have our able-bodied workers in Pennsylvania that their work requirements have been waived. You know, if we were just reaching out to the several thousand that are living here in Westmoreland County and saying, you don't have kids, you're not caring for an old person, you have to work 20 hours a week, and you can choose to come to a training, you know, here. You could go to the prison needs people, the manufacturers need people. How, if we were able to integrate a workforce training program within your facilities or within your home programs, would that benefit everyone? Because the money is being spent. I mean, it's happening and it's being reinvested, but it just does not seem like it's being prioritized into the senior industry. There's silence across the board.
I mean, I agree with you. I think there's been investment. I think it's just how do providers that are, their main function is to provide for seniors, and that's what they're good at. Like, we then throw a bunch of hoops and barriers and obstacles and, you know, say how high can you jump when really your whole, you know, their whole purpose is to care for seniors, not trying to unlock these dollars. It's very, very complicated, and I think that's why we've seen a lot of folks get out of the training side of it when it comes to CNA training and the workforce investment. Like, they want to take advantage of it, but also we're trying to keep our heads above water.
I do
think it's also just the good jobs question. Like it is a challenge with the home care, the PSA rates as they are. Home care workers the average is $13.30 an hour. So like that's the average. So many people are much less than that doing the work. So it's like it's also how are we going to get, like it's going to require enough money directed in the system to get the jobs to where people will take them. And it's not, and I don't mean to make it sound like it's just about money, because like it takes a lot, it takes a big heart to care for people, but it's also like in this economy, people have to be able to earn a living and be able to, and caregiving jobs, whether they're entry-level jobs or not, have to be a living wage job. And I just think that continues to be a challenge. That's been a challenge for as long as I've been advocating in this space, which is now 26 years, believe it or not. It's just like, it's been a challenge. Like when I started as a nursing home worker in 1998, my hourly rate was $7.05. So like, it's just like, we haven't moved mountains. I think right now through a lot of good work, on average, where people are walking in the door between $18 and $20 an hour with no experience for CNAs. Like that's not a huge spread over those years. But then we have home care workers who are still completely in the dust, that we have to make real investment improvements to be able to get people to stay, to do care in the community as well. So anyway, I think that's yes, let's figure out how do we pull the resources together to actually get the job training programs to produce more people, and at the same time, how do we lean in together to make these living wage jobs, which I think means more resources and making sure they're getting to where they need to.
Great. As we look towards closing comments, Chairman Struzzi.
Thank you, and thank you all for being here. I think we've heard a lot of useful information. Clearly, there are really significant challenges before us, and I do go back to one of the initial questions that I had related to community health choices. Can we fix this system, or do we need a new system, or do we need no system? I mean, there's a layer here that seems to be taking a lot of the money that should be going directly to services and the people who need them. And I think we really do need to take a hard look at this system 5 years in and find out if it's possible to fix it, or do we need to look at a different way to deliver the essentials that our residents here in this Commonwealth need. So again, I appreciate Representative Nelson, Representative Brown putting this together, everyone who came today. This has been very, very good information, and I appreciate all the work that all of you do on a daily basis to provide for the people that we represent. So thank you all.
Whip O'Neill.
Look, I appreciate the opportunity just to hear some discussion around this issue. Clearly, one of the driving factors in the budget increase that Representative Nelson highlighted has been all around this issue, and DHS funding and funding increases year over year. So that'll continue to be the case, and I think Cody made the comment that the system as it is doesn't seem to be sustainable long term, and I would wholeheartedly agree with that. So figuring out how we can do this in a manner that is both effective but also able to be controlled from a cost perspective standpoint, I think is vital for our budgeting process moving forward, and it's certainly a very important discussion to have. So I appreciate all of your time. I appreciate being able to be here for it. So thanks.
I just want to thank you, Representative Nelson, for putting this together. This is a vital conversation about our most vulnerable population. These are the people that helped raise us, and we have a responsibility to take care of them. So on that note, Carol and Janessa, thank you for what you do day in and day out. Yes. But also to those of you that continue to advocate for this population, thank you. Don't stop, because it's so important, and it's frustrating being on the Appropriations Committee, knowing that we have this huge budget increase that we're trying to wrap our arms around, and hearing that it's not getting to the people that need it is very frustrating. So we have a lot of work to do. But we appreciate the time that you've given us to help navigate some of this.
Yes, and with that, we're going to draw this hearing to a close. Thank you to the Westmoreland Manor. Thank you, commissioners, for hosting this and, helping to share the perspective you're seeing, concerns you have not only with the manor, but with the residents here in Westmoreland County. Appreciate everyone and look forward to working with you moving forward. Thank you.